Treatment Not Trauma is an initiative that's been years in the making in Chicago that's been embraced by the new mayor, Brandon Johnson, a policy agenda to build a robust non-police crisis response system for the city of Chicago, to reopen a total of 19 community mental health centers that used to be run by the Chicago Department of Public Health, but have since been closed, except for 5 of them still continue now, although largely defunded and destaffed. And then the most important and exciting part, in my view, of the whole agenda is this third component, which is building out a large-scale community care workforce to fundamentally transform what public mental health systems mean, what they can look like, what they do, to move away from both police and psychiatrists towards a community conceptualization of care, a demedicalized, democratized form of care. If we're going to design effective community mental health infrastructure, we have to relocate the center of power for that, the center of authority, the center of funding, away from professional workers into communities themselves, into workers who are employed from these communities who do not have necessarily fancy degrees, but have everyday lived experience that's incredibly important for delivering effective care and designing effective care delivery systems. It's very, very difficult to get access to mental health care in the city of Chicago, like it is in most places in the US, if you don't have adequate resources to pay for it. The other issue is that the quality of care that you get isn't really that great because it's largely built on a psychiatric model that's reactive. You have symptoms, you have disease, we'll give you a medication, we'll give you a 10-minute appointment. And the fact is those medications aren't very effective. Our own studies within the field of psychiatry have shown this time and time again. There was a meta-analysis published last year, I believe in 2022. John Ioannidis was one of the authors of it, that looked at the history of randomized controlled trials within psychiatry and looked at the effect sizes of both psychotherapeutic and psychopharmaceutical interventions. And what they found is the effect sizes are tiny. And this hasn't really shifted over the years. We aren't good at what we do within the field of the mental health industry, more or less. But people don't have other options. And they don't have other options because we, the professional systems, the professional workers, gobble up the funding resources. It's incredibly ineffective and expensive. And what we see is that there is no strong association between the density of mental health providers and overall mental health disease burden dropping. It doesn't seem to do that. And in fact, studies have shown that if you provide really high quality care, high density care, that the proportion of burden of mental health symptoms that you can reduce is actually pretty small. It's like 20 to 30% in most cases. So the business as usual model, I'm using language now that Vikram Patel and others have used in a recent article in Lancet on redesigning mental health systems globally. They say the business as usual model that we have right now is failing. And we need to confront the fact that the way that we've designed our mental health systems isn't working. What we're trying to do in Chicago is to take on that lesson and say that simply putting more and more money and more resources into a failing model isn't the solution. People should have access to care, absolutely. We should have more money for this, but we should have more money that's invested smartly in addressing root causes and delivering the everyday supportive care that people need, not in more emergency department funding, for example, or necessarily inpatient psychiatric units. These things can be important, and medications can be really important too for some individuals. But when you try to make these kinds of medicalized forms of care do more than they are capable of doing, what you end up doing is causing harm. And at a systems level, that's absolutely what the mental health industry in the US is now doing. We have to have a new model. So that's what Treatment Not Trauma is trying to do. It says we need places for people to go when they are in crisis, when they're struggling, or ideally before they're in crisis, when they need support, when they need connection, when they need just social care, everyday social care. When they are in crisis, they shouldn't have to call 911 and have police officers come, which often results in violence. People with unmet mental health needs have a 16 times greater risk of being killed by the police than anybody else in the US right now. They should be able to have community care workers respond to them, people who are perhaps mental health specialists. Maybe that means professional workers. Maybe it means people who are non-professional workers, but are trained to respond to mental health crises in the kinds of systems that we're designing, like Treatment Not Trauma. So you need those two systems. You need crisis response, non-police crisis response. You need places for people to go, home bases for care teams, and then you need a workforce. We can call them community health workers, but what we need is to empower residents of dispossessed communities where there's very high rates of just everyday social needs that then become transformed into so-called psychiatric needs when they aren't met. We need to employ those kinds of people, give them adequate support and training. That means compensation at a level equal to what the police get right now, for example. So in Chicago, you start in the high 50s as a 550,000 as a police officer, and within a few months, your salary increases to about 80,000, and you have really robust benefits, good job protections. We should be giving that to care workers. Why are we always investing money, more and more money in the US in punishment systems and punishment workers rather than in preventative care workers? That should be a career position. When I talk about this with people, they often say, oh, you can't consign people to these low-level poverty jobs as community health workers. What's often taken for granted is the idea that a community health worker should be a poverty job. That shouldn't be a poverty job. That should be a career job. That's an incredibly important role that we as a society should value. And it shouldn't be based on what kind of revenue you bring to a for-profit health system. It should be understood as a public service, just as the police are right now understood as a public service. We should have community care workers that are employed by local Department of Public Health to do this. What this enables us to do is begin to think about non-pharmaceutically based models of care, which is really, really important, because something that is not talked about enough, I think, in the US right now, is that the very high rates of psychiatric prescriptions also carry a lot of iatriogenic harm. Antipsychotics, for example, can result in elevated blood glucose levels that over time can drive diabetes. They have all sorts of metabolic disturbances that they affect. We don't fully know the range of harms that a large number of psychiatric medications may cause. When we have other kinds of systems, then we can begin to prescribe more judiciously, more carefully, in a way that's designed to be effective for each individual patient, rather than just as a reflex. Somebody comes to me, I give them a drug. So I think this is what treatment not trauma enables. It's not just about a public care system. It's not just about non-police crisis response. It's about transforming our entire conceptualization of what community mental health is, of what mental illness is. Is mental illness perhaps in many cases just unmet social needs that, if we meet, no longer require psychiatric response? They don't require psychiatric attention. So a lot of basic definitional issues are raised by this kind of model of care. And I'm very excited about the possibility of trying to build something new that would allow us to negotiate these longstanding questions and problems in a very different kind of way when we have the backing of a real public care system.